Would you like to work closer to home, save money on gas, and be rewarded for your hard work and attendance? Then Bellisio Foods is looking for you. That's right, Bellisio Foods is now hiring for multiple positions and shifts with great employee benefits, an on-site health clinic, competitive wages, and advancement opportunities. Bellisio Foods is a company that truly values their employees. Apply online at BellisioFoods.com/careers.
Well, good morning, everyone, and welcome to the morning show right here on Main Street TV, where we have a very special guest, one of our guests from Holzer, which, of course, we love to have here in the studio because you find out about all kind of great services that Holzer has to offer. And welcome. We're so happy to have you here.
Thank you. Yeah, happy to be here.
And this is Dr. Dylan Lewis, and you were telling me that you actually grew up in Oak Hill.
Yeah, so I'm an Oak Hill native, graduated from Oak Hill High School in 2011, I guess.
And then you left us.
Yeah, I was gone for several years. Went to Ohio University for my undergrad, stayed for med school, spent a year in Columbus for my internship at Riverside, and then I was at University of Louisville for the past 4 years for my residency and fellowship. So, but now we're back home, so we're excited to be back and get settled in and back in the community.
And here you are, and here to help the community, and that's great.
Yeah,
and
yeah.
you know, as you said off the air, you have 2 little ones, and it's nice to come back to our small, fun little community and have a village to help raise them, right?
Yeah. So we had no family around the last several years, so it's nice to be back. And grandparents and aunts and uncles and cousins and people around.
All the people.
Yeah. So, but yeah, my oldest, he's starting kindergarten at Southview this year here in a few weeks, or next week, I guess next Friday. So. That'll be a big step for us, but we're excited for him. It's time.
All right, how are you doing, Dad? Are you handling it well?
Yeah, I'm okay. We'll see how the first day goes. My wife may not take it as well, but I don't know. He's in a stage now where he's hard to handle at times, so she may be happy to get him out of the house for a while.
Let someone else deal with that for a few hours,
right,
and then.
Right.
I don't know. Is kindergarten every day full time now?
I
don't even know.
think so. They do a staggered start, I think, to let them get acclimated. But as far as I know, it's every day.
Oh,
that's my wife.
I'm trying to. Yeah, right. That's the wife. The wife knows on that stuff. Yeah. I can remember going to kindergarten and it was like half day every day. I think is what we did.
Yeah.
So I was just wondering about that, but that has nothing to do with what we're going to talk about today.
Part of the community, I guess.
Yeah. So you are technically what are you?
So I'm an interventional pain specialist.
Okay.
So that's kind of what, if you look on the like Holzer provider search, that's the tab I'll be under. So we treat a huge range of painful conditions all over the body, sort of head to toe. Most of what I do is spine related. So a lot of spinal issues, herniated disc and spine arthritis and spinal stenosis, those kind of things. But also a lot of peripheral joint issues, hips, knees, shoulders. And usually those patients fall into a few different categories for the orthopedic issues. Usually it's the patients that either don't want to have surgery or they don't want to have surgery yet. The ones who can't have surgery because they have too many, medical comorbid conditions to undergo anesthesia. It's just too high risk. And third would be the patients that have had surgery already, but they still have significant pain. Those are usually the ones that end up in my clinic. And then we see a different, range of patients that with less common chronic regional pain syndrome, which has sort of been popularized the last few months from this. There's a Netflix documentary about that young girl that ended up on the ketamine infusion. I don't know if you saw that, and her mom.
No.
So.
All right, now you got to tell us all about that.
Yeah, well, it's actually a very sad case, but anyway, people ask about that now because that was on Netflix recently. I can't remember Anyway, yeah, that was it was more of a medical ethics thing, but that was her condition. And then cancer-related pain. Those are patients I saw a lot of in my training. Because chronic pain is not really something that people think of with cancer.
Right.
But it affects a lot of cancer patients, and a certain percentage of those are somewhat undertreated. But usually the oncologists do a good job with medication management. There's often other things that we can offer that are targeted procedures, nerve blocks, nerve ablations, neurolytic procedures, implanted pumps, and things like that can be helpful for those patients sometimes too. So.
Well, you do it all. Sounds like.
Well, yeah, that's
That's a lot.
there's a lot of different things, so that's why it's hard to I think from a marketing standpoint, like what do we do? And it's hard to, it's not like a cardiologist deals with heart problems and a nephrologist deals with kidney issues.
Sure.
We sort of get a smattering of patients from all, issues all over the body that come to us to see if they can get help. So.
Gotcha. It's kind of like being like a family doctor where you have to know a lot about a lot.
Yeah. Painful conditions all over the body and what goes with those. So.
Wow. Okay. So what made you choose this particular specialty?
Yeah. So for me, I think most people when they go to medical school, a large chunk of them either want to be orthopedic surgeons or they want to be pediatricians because they've been a kid who's had a pediatrician or they've been an athlete and they've had some kind of sports injury. So it's just what they know.
Sure, they relate to it.
Yeah, exactly. So
that makes sense.
I always liked musculoskeletal injuries and things like that. It was always fascinating to me, I guess, from like a sports perspective. And then for pain management, it's sort of, there was a lot of patients that I would see go through other services that they didn't really have much to offer these patients surgically, but they still had pain, and then sort of pain management's where they end up. And I spent some time, shadowing in medical school and rotating with them, and they had a lot of sort of just creative solutions for these patients. Or patients that thought they had no other options left, just had to suffer.
Thinking outside the box stuff.
Yeah,
that
exactly.
Seems fun, like the challenge of it.
Yeah. And for me too, like when I, sat back and kind of reflected on it and what I was going to do, like to be a physician, I wanted to do it obviously to have a personal one-on-one impact with patients, and my sort of whole goal is to ease pain and suffering and improve function. So that sort of embodies what the physician is to me. That's why I chose it. So.
Yeah, that makes sense. So when you went into medical school, did you know that this was
I didn't even know this
route?
No, I didn't even know this even existed. It wasn't on my radar at all. And I sort of because we're a relatively small subspecialty. Even in systems of hundreds of providers, there's usually like 2 or 3 of us, so it's relatively unknown. And like I said, I had no exposure to it prior, but yeah, this is where I ended up. So,
well, very good. Well, we're happy to have you here.
Yeah.
Well, let's talk about, I don't, elephant in the room isn't a good term, but like, so the first thing you hear about is you hear pain management doctor. You're like, oh, yeah, right.
Right.
Because pain management doctors got a pretty bad rap several years ago where there were these pain management clinics, which was basically drug dealers.
Yeah. So and that's well documented, even like in like Dreamland, is the book based off of all these pill mills, how they developed in like the Portsmouth area and things. So every now and then you'll hear patients or primary care docs will tell me like, oh yeah, I want to refer a patient to you, but they immediately like, I don't want to get hooked on pain meds. And frankly, we don't even, there's very, very few patients that we even discuss a pain medication with. Usually it's the cancer patients and then very rare other exceptions. There's not a lot of prescribing that goes on anymore just because the evidence for it is not very good. So it's good for short-term pain relief, but for long-term pain, any kind of opiate for most patients is not the right answer. It just doesn't improve the pain long-term. It actually can make things worse. They can develop what's called opiate-induced hyperalgesia, where actually long-term their pain and sensitivity to pain increases.
It gets worse.
Yeah, it gets worse. So, so that's why even at a society level in our specialty, we've had, there's been a lot of sort of remarketing and rebranding and patient education to say like, hey, we are an interventional specialty. We do interventional procedures to try to target pain, just like a surgeon would do surgeries to target pain. We do prescribe medications, So as an interventionalist, we sort of split the difference between traditional medical specialties and traditional sort of open surgical specialties. We kind of fill the gap in the middle to do up to minimally invasive surgery down through injections and also prescribe non-opiate medications a lot of times. So yeah, there's definitely a, if you say you're a pain doc, there's sometimes some stigma with that.
I wanted to address that because I wanted to make sure that you explain that, we've gone to a whole different place with pain management now.
Yeah. So and frankly, those are the patients we can help the best anyway. The ones that come in with a sort of one area of the body that's really giving them trouble. If it's the sort of total generalized pain, that's a lot harder, obviously, to treat because we don't have a lot of targeted options for that. But yeah, I think it's important to just kind of educate the community and as far as what we do and what we can offer. And there's a lot of patients that again they never wanted to go to pain management because they didn't want to be on medication. That are maybe needlessly suffering that maybe I have, I or one of my colleagues have something that to offer those patients that could help.
And I think it's just important for all of you to understand that if you have chronic pain, this is what he is doing, and the last thing you want to do is prescribe a pill for it.
Correct. Yeah.
We want to fix the problem. So what are I'm just interested in like what are some of the or what are the most of the patients that you see, or is it just all over the place as far as pain goes, and why they have pain?
Yeah. So I would say, like, we see less acute injuries. Every now and then we'll see like a disc herniation that happened last week, right? Someone's moving furniture, they hurt their back, something like that.
Okay.
Most of it is like, doc, my back has been killing me for months or years. I can't take it anymore. I asked for a referral. Or I went to a surgeon and they said there's nothing surgically they can offer me. This is how I ended up here. For the spine patients, yeah. Or again, like in the cancer population, the oncologist maybe has them on medication to try to control their symptoms, but then it's just not quite enough, right? And these patients are starting to have side effects, and they will refer to us to see if there's something we can offer from a procedural standpoint
Sure.
for these patients.
We want to fix the problem, not mask the problem.
Yeah, or at least address it, at its nature. So, I'm not saying we're curing anything, obviously, but we're sort of treating. It's a palliative specialty, so we're treating symptoms. We're not, if someone's got, say someone's had their knee replaced. There's a percentage of those patients, they go back, their knee still hurts for whatever reason. We're not really sure in a lot of cases. The surgeon looks at the hardware, they run some scans, there's no evidence of infection, the hardware is not loosening, their knee just still hurts, even though they've had a total knee replacement.
Sure. Whoops.
So those patients, for instance, like they get, a lot of times we would offer like a genicular nerve block, nerve ablation, where basically you're taking the nerves that provide sensation to the knee and you're destroying those to basically stop the sensation. So the knee doesn't hurt anymore. So we're not curing the surgically repaired knee or anything or fixing that, but we're sort of addressing the pain in a different fashion. So
Okay. Wow.
yeah, but I would say
That sounds fancy.
we're probably it sounds way cooler than it is, but yeah, we're probably like 70% spine, I would say, and the rest is just a mix of orthopedic issues and some random other things. So, and everything we do pretty much is image guided. So we either use an ultrasound machine to guide a needle for a procedure, or use like fluoroscopy, which is sort of like live X-ray in real time that we can use to make things precise and safe for the patient. So especially with the spine stuff, right?
I was gonna say you start talking about spine and like I get chills.
Yeah. So if you're working, within millimeters of spinal cord, you need to make sure you can do things safely for the patient. And that freaks, just the idea of that freaks a lot of patients out. So.
I mean, it's like, ooh.
Yeah, I understand.
It's so interesting that you're here today because I have a very good friend who used to be an orthopedic surgeon and he has since retired, but he was in yesterday and we were talking and he was on, he's getting ready to have something done with a disc in his back. And he was actually, he said he just woke up one day and went to stand up and his leg just stopped working. Like he just fell over. His wife's like, I thought he died. Like, I didn't know. And, but anyway, he was showing me his x-ray and I was like, ooh.
Yeah, you never know. You never know.
Yeah.
I had a friend of mine in residency. She was young and active and fit, healthy, no issues. And she was playing sand volleyball, went up to spike a ball, came down, landed, and massive disc herniation. She had the same thing, just shooting pain down both legs. She ended up having surgery a couple times actually, but yeah, these things happen.
So wild.
Yeah, it's crazy. So don't get hurt is my best advice.
Yeah, stay out of car wrecks and all of the things. Yes, don't fall, don't do anything.
Fall off ladders, that kind of stuff.
Lift with your knees.
Yeah. Don't bend with your back. Keep your core strong. All those kind of physical therapy tenets will serve you well. So.
All of the stuff. Okay, so you are at Holzer. What location are you practicing?
Yeah, so I'm just up the road in Jackson. So I'm on Burlington at the
hospital location.
Yeah, that's where the physician specialty offices sort of live now.
Okay.
So I'm there 3 days a week, and then 2 days a week I'm at the surgery center at the clinic up on Pattonsville.
Oh, so you're here in Jackson all the time?
Yeah, I'm in Jackson all the time. So, yeah. That's right. I wanted to be as close to home as possible. And,
we're happy to have you.
We live here in Jackson. So
you do? Okay. Yeah. Well, I guess you said your son was going to Southview.
Yep.
So exciting.
Yeah, we're excited to be back. So it's been good so far.
Yeah, very good. So, I guess I wanted to kind of like dive into a little bit about, and I know you've touched on it, but can we dive into a little bit more specifics on, say, take the spinal cord stuff, for example, and somebody comes in, they're like, man, I have this horrible back pain. been to a surgeon. They can't do anything for me. What would be like, let's walk through like what would happen. Like, what would you do? Would you take an x-ray and then what would you do from there?
Yeah. So every patient, if they don't have any imaging of any kind, we usually would start with x-rays.
Okay.
Just get an idea of what's going on. It doesn't show you a lot of soft tissue issues or disc issues and that kind of stuff, but at least shows you where the bones are and you can kind of infer some clues from there.
What is the difference between an x-ray and an MRI?
Yeah, so an x-ray just shoots.
I don't even know.
Yeah, an x-ray is like you get one view. It's just a picture of, and you can take different views. The patient turns in the x-ray, but they just shoot x-ray in one direction and it shows you where the bones are. A little bit of soft tissue stuff you can infer from those, but usually it's sort of like a basic scan. It takes, half a second to shoot an x-ray and that's it.
Okay.
An MRI is basically using magnets to create an image. So you're on a table, it slides into a big oval tube, kind of like a CAT scan or something.
Tube.
Yeah. A magnet spins around
that
super
would completely freak me out, by the way. But anyway.
Yeah. Some people are really claustrophobic.
I couldn't.
They have to have medication for to go in.
Knock me out.
So basically, a magnet spins around them very quickly. When the magnet goes around, all the cells in your body are polarized. They have like a magnetic field, so those will turn and turn back based on the density of the tissue. They flip back and forth.
Oh.
The machine also can basically sense that, and then it goes through a software, spits out an image. So it's a much more. It didn't come around until like the '70s, early '70s, whereas X-ray has been around forever.
Okay.
Or not forever, but hundreds of years, 150 years or so. So it just gives you, it's a longer, for the patient, they might have to lay on the table for 45 minutes or half an hour or something.
Take you a nap.
Yeah, so it does take longer, but depending on what you're looking for, it's much more detail into kind of what's going on with the patient. So it has its time and place, but that's what we end up getting from most of our spine patients, depending on what kind of conditions they're suffering from. So.
Okay, so you start with that, and then you say, okay, well, this is what I'm seeing.
Mm-hmm.
And then you say, okay, what would be a couple of the different options?
Yeah, so say someone has arthritis.
Knowing that we're not going to just give you Percocet.
Yeah,
Okay.
yeah, correct. Yeah, not pain medication.
Oh, here, just take it. It's fine.
No, yeah, not pain medication. So say someone has arthritis in their low back, right? We get some imaging. We confirm that's what's going on. The patient's history, the physical exam, it all matches up. We think they just have some arthritis in the joints in the low back, which is pretty common, and that's what's bugging them. So again, we always, unless someone is like debilitated from pain, then we sort of skip a few steps and go to the more invasive things. But say someone is just, their back is stiff in the morning, they're having trouble at the end of the workday, that kind of stuff. Usually would start with just like some anti-inflammatories, Tylenol, that kind of stuff. If they can take it, heat, ice, maybe chiropractic referral if the patient's interested in that. Almost all those patients go to physical therapy. There's a lot patients can learn from PT, just as far as like how to fire certain muscles in a certain sequence and strengthen their core and stay flexible. Ways to basically avoid further injury and try to sort of tune their body up to function better and move better ergonomically.
That makes sense.
Yeah, so we kind of start there, see how things go. If they're not responding, then we talk about other procedures. So for that patient, they may be a candidate for what we call like lumbar medial branch blocks, which is basically, again, taking the nerves to innervate the joints in the low back, putting some local anesthetic there to sort of numb those nerves, and then see if the patient responds. So if they respond and they get excellent pain relief, even if it only lasts for a couple hours or a day, it's just a diagnostic procedure to say like, hey, is this going to work if we do something further? If it does, then we can go in a second or the third time, technically, because the insurance wants us to do two to confirm that's the real problem. So that's the joys of dealing with insurance.
Because you're a dum-dum and don't know it the first time, right?
Well, yeah, and there's someone writing rules that doesn't have clinical experience usually, but
no.
Yeah. So anyway, then the third time we can go in basically with a special needle that creates a small lesion, basically, so it destroys the nerve in a very like targeted, precise fashion, and then until that nerve grows back, the patient should have relief of their pain, assuming that's their issue. So, it's still all just like anything else. It's all about diagnosis. You got the perfect treatment for the wrong diagnosis will never work. So you got to figure out. Low back pain is not a diagnosis, right? It's you got to figure out exactly what's going on. Or a good idea before you can try some of these things. But
this is why we don't just prescribe pills, Kay.
Yeah, we're not just throwing out Band-Aids through the mouth to try to go everywhere and see if it helps. So, but there's a lot, like I said, there's a lot of different options, a lot of things we can offer. We can't fix everything certainly, but there are a lot of patients certainly that could benefit from our services that are out there and they're just not coming in for one. They just don't know about us. They have a misconception about what we do. So,
well, and that's why I want to clear some of that up today, because it is, I think, you hear pain management and you immediately go to the wrong place.
A lot of folks do, unfortunately. So, and I understand it.
There's a lot of people that created that.
Correct. Yeah.
So through no fault of your own, you get,
certainly
sometimes.
Certainly not the patient's fault either, right? It's just this is the way, unfortunately, things unfolded, and there's a lot of influences, multifaceted problem. But
that's for another show.
Yeah,
we
I'm not
probably get ourselves in all kind of trouble talking about a lot of that stuff. But.
Correct.
So what are, I was just sitting here thinking, what you do has to be fairly rewarding. As you see someone come in and they feel horribly and they are in horrible pain, and then all of a sudden you can help them. Yeah,
and like I said, especially if it's like they have one problem area of their body, right? It's their left knee is always killing them, or their back, or you have a cancer patient that maybe they define they're in remission, but they underwent chemotherapy and now they have neuropathy from the chemo that's very painful, or they had radiation injury or something, and to make them better or to feel better, and you can really improve their function, quality of life. Yeah, it's super gratifying. That's why I love what I do. So
so let's talk about cancer for a minute, because luckily, as someone that hasn't had to go through the treatments, but obviously we all know many folks that unfortunately have. And I have two very good friends right now, young, going through breast cancer treatments, and the neuropathy in the feet and the foot pain is unbearable for both of them. And why?
Right.
And B, what can be done about that?
Yeah, so,
and I'm not saying they're not being treated for it. I'm just throwing it out there that I know. Yeah. And I didn't know that was a thing with cancer treatments.
Yeah, so certain chemotherapy agents, and these are all these chemotherapy medications. There's newer things like immunotherapy and stuff that have a lower side effect profile that are more targeted, but we just don't have them available for every type of condition. But for traditional chemotherapy, these are toxic in one way or another, right? That's how they treat the cancer, essentially.
Yeah, it's
unfortunately
bad stuff going into your body.
Yeah, it's like a poison of sorts, sort of, to put it in that kind of term. But so a lot of them, classes of chemotherapies are neurotoxic, so they're just hard on the nerves, and it usually starts in the feet because those are very small nerves and they're very far away from. They have the least amount of sort of blood supply and nutrition ability to heal themselves. That's why patients that have diabetic neuropathy usually, it starts in their toes and then moves up their feet.
Is it because it's the farthest from your heart, or is it just because
it's more that the cell body of the nerve lies just outside the spine? So, and that's what sort of keeps the nerve healthy and can sort of track nutrients on a microscopic level up and down the nerve. Okay. So when it's super far away from that, it's hard to repair it, essentially. So that's why patients with diabetes that have neuropathy, we call it like a stocking glove distribution, because it's like stockings, basically. It starts in your toes, move up like socks would, and then it ends up like a glove distribution in your hands and kind of goes more proximal as it gets worse. So same thing can happen with chemotherapy agents. As far as treatment, usually, and it's not always the case. Sometimes once the sort of neuropathy is there, it doesn't really get better. Some patients do improve some, just like patients that have diabetes, that have neuropathy. If they get their blood sugar under control, they do have some ability to heal those nerves. Okay. But sometimes the damage is
There's hope.
Yeah, sometimes the damage is too severe. That being said, as far as treatment option goes, if it's in the legs or the feet, say, there's obviously medication, like nerve pain medication that's out there, the gabapentin and Lyrica, some of that stuff people have heard of. Cymbalta or duloxetine.
The stuff we see on TV.
Yeah. I actually had a patient yesterday I counseled, and that's what they were saying. Like, I saw a commercial for that, which isn't, again, that's another whole thing. Only in the U.S. can you directly advertise drugs to patients. But
again, it's so ridiculous.
It's a system thing that is out of my control. So, so there's medication options. There are a lot of topical things, so like creams and patches and things that can be helpful sometimes. Some of them are just like numbing creams. Some areas they have like compound creams available, so you can actually get like gabapentin and ketamine and numbing medicine and anti-inflammatory into a paste, sort of, that you can put on those areas. That's helpful for some patients. There's another like capsaicin, which is like a hot pepper
Yeah.
compound. Yeah. So there's creams that have that. There's also a company now that makes one that's like 16 times the concentration of what you get over the counter, and it comes in a patch you put on like every 3 months. You have to come in, a nurse does it, and it basically there's a few different mechanisms it works by, but it can really, I've seen patients do really well with those. If none of that works, then you start moving on to like nerve blocks and stimulators. So a nerve stimulator, again, like you can either modulate the pain signal at the level of the spinal cord, or there are now peripheral nerve stimulators where if it's more targeted and say you don't need to cover like all the legs like you would if you hit it in the mid spine, say it's just one area, then you can go to the peripheral nerve that would cover that area as well. So there's different interventional options that you can use to treat these kind of things.
Okay, how do you stimulate what you said?
Like a peripheral nerve, like in the leg or something, or the spine.
Like the spinal thing.
Yeah, so that's...
How do you... It's like you can't just turn up a dial.
Right, yeah, yeah. So that's... so spinal cord stimulation is basically all these, like, there's spinal cord stimulators and peripheral nerve stimulators. It's sort of stimulators. They're sort of like pacemakers for the spine, so to speak. So there's sort of like wires that have, or leads as we call them, that have little contacts, and they can deploy electricity at certain amplitude, waveforms, pulse widths. There's all kinds of programming that goes into it that the device reps are really experts in. So what it looks like for a spinal cord stimulator is basically there's only certain indications that you can do this for, but one of them is diabetic peripheral neuropathy and failed back surgery or post-laminectomy syndrome. We talked a little bit about those patients also indicated sometimes. Essentially, you're putting two small wires or leads inside the spinal canal, just up against the spinal cord, essentially, and then you basically can test drive it for a week. So for a week, those wires come out of the skin. They're attached to an external battery pack. The patient goes home. They work with the rep, see if it helps them.
Okay.
If they get great pain relief, then the second stage, then you basically come back to the office, pull everything out. You do a permanent implant, which is the same thing. You basically put the two new leads back in, and then you create a small pocket where you put a little battery, just like a pacemaker-sized battery, underneath the skin, usually in the back, either on the flank or the hip.
Okay.
And then that's a permanent implant. So the patient there's chargeable and rechargeable ones. That's a whole nother discussion, but
I gotta go plug myself in. So overnight or what?
Usually the chargeable ones, it's like a band you would wear, and then it has like a battery that's kind of like Bluetooth, right? So you just wear a band at night once a week or something. A lot of patients plug themselves in.
Where's Dad? Oh, he's plugging himself in for a minute.
Yeah. So, but and then some patients, even the non-rechargeable ones, their battery life is like 5 to 10 years. So every 7 or 8 years they come in for a very minor surgical procedure to switch a battery out.
Just to switch a battery out.
But
is this why what TENS units do? Is that the same?
Yeah, same idea. It's just a TENS unit goes on the skin. It stimulates the muscles and sort of the superficial nerves. This is all originally based on what's called like the gate control theory of pain. So essentially the idea is that your body can only interpret so many nerve signals at once. So if you take painful signals that are flowing through and you interrupt them with sort of like a normal or a buzzing sensation, then it sort of overwhelms, and basically your brain stops interpreting the painful signal because it's just getting too much stimulation. So you're sort of modulating that signaling of pain to decrease it.
So it's like your body gets ADHD.
It's electricity is medicine. So it's sort of a wacky concept, but again, if you select the right patient, it works really well. So,
and that would have to be very frustrating for I think someone in your field, is that all humans are different.
Yeah, it's hard.
And you have someone walk in and you're like, I know exactly how to fix this person up, and maybe not. Yeah.
So I mean, that's true in a lot of medicine. Like I said earlier, the diagnosis is the most important part. You got to get there, and then you can figure out the rest. But yeah, that's how a lot of patients end up in my clinic are from orthopedics, right? So orthopedics gets referred to shoulder. They look at them and they're like, I think this is actually their neck. It's not really coming from their shoulder. It's a spine-related issue. Or the same for the low back. They get referred to hip for hip pain or hip arthritis or something. They look, they're like, actually, I think it's coming from their low back, or their SI joint, that kind of thing. So, even in the low back, if you take one area, there are so many things that can cause pain that really drilling down on what the diagnosis is the most important thing. And that's what I was saying earlier. That's why it's important to patients have one area of pain that's targeted. We can usually figure out what's going on and treat that. If it's just generalized pain everywhere, that's much, much more difficult to find a good solution for. But not that we don't have anything to offer, but it's very difficult for a lot of those patients.
I can see that. And what would be a reason someone would have, all over pain, I guess, like arthritis? My mom has horrible rheumatoid arthritis.
Yeah.
She's in a lot of pain all the time.
Yeah.
Which
Rheumatoid arthritis,
is a whole other
multiple sclerosis,
MS, yeah.
patients with like Ehlers-Danlos or hypermobility syndromes. If you're familiar with any of those things, MS flares, you see a lot of it.
Okay.
Patients with, say they've had a stroke or a spinal cord injury, they get sort of like whole half of their whole body, they have neuropathic pain. Fibromyalgia is another one that's sort of we don't really know what's causing it. There's a lot of theories out there, and those sort of play into what our treatment options are, but they are just they have a heightened response to stimuli. So
Okay.
just some patients, like, things that should not be painful are painful. We call that allodynia or hyperalgesia. They sense things so much more severely that things that, again, shouldn't be painful can become very painful. And there are some options, but again, that's a difficult condition to treat. And, a lot that's even in fibromyalgia specifically, and they have to meet certain diagnostic criteria, make sure there's no other organic cause. But for those patients, they have trouble sleeping, they have trouble exercising, they have trouble communicating. It's the social aspect, right? Because no one, if you got a cast on your legs, it's obvious what's going on, right?
Sure.
But if your spouse or your friend can't see anything wrong with you, and you're like, I am in terrible pain, I can't
They're
go.
like, you're full of...
So it's hard to communicate it, right? So those patients it's hard for us to treat, but it's obviously very difficult for the patient sometimes.
Sure.
And another thing is what's studied the most in that is the exercise is one of the best treatment options, but it's hard to get over the hump because
it's a catch-22.
It's painful to exercise, right?
Yeah, like you can't start because it hurts, but then you have to exercise to get better.
Yeah, and a lot of them get a lot of fatigue, so like if they overdo it one day, then for 3-4 days after, they may be like not be able to do much. So activity pacing and some of that stuff, it's just, there's a lot that goes into treating that, but a lot of it is the patient just has to take responsibility and try to manage it themselves. So we have tools that we can give them. There's just not I can't pull out a procedure or something that I can do to treat them very well. So it's difficult.
Can guide them along.
Yeah, correct.
But they have to, and that stinks. You have to have some willpower.
Yeah, it's hard,
tough.
right? Because they've been suffering forever, and then they come to me for a solution, and I'm like, I can guide you, but this is kind of up to you. And we have some things we can try. There's just not a lot of great options.
There's no magic bean for you.
Correct.
So, okay, I'm just going to ask you this because I'm sitting here thinking about it, though. Back to the pills.
Mm-hmm.
And you're talking about, different procedures and doing diagnostic, care and
Correct.
all that. How do the pills, what do they do to the body why do they work or not work or?
Right. So we all have opiate receptors in our brain and spinal cord.
And why are they a thing?
Yes. So everyone has those because it's sort of your body's natural mechanism to deal with pain, right? So certain hormones and cellular signaling can happen to decrease pain, right? So again, if you go back 1,000 years to if you were injured and you had a predator around, you still had to be able to get away, right? So there's things that these mechanisms are in place for a reason. We sort of developed this way.
The human body's insane.
It is, yeah. So, but what it is crazy. So, but what the medication does is basically exogenous opioids, right? So you're taking something that's usually an internal signaling mechanism, taking it in a pill form to sort of saturate those receptors to decrease pain, which sounds awesome, and it is. It works really well for a short period of time, but there's so many long-term side effects in terms of there's a lot of hormonal changes that can happen. So, like in estrogen and testosterone disruption, hypogonadism in men, fertility issues in some men, loss of bone mineral density, so like osteoporosis you can develop sooner, chronic constipation, the opiate-induced hyperalgesia we talked about. So you're actually, the idea is that over a long period of time, as you saturate those receptors more and more, your body tries to regulate that by decreasing the amount of available receptors. So then what happens is in the long term, your pain can actually become worse. So there's a lot of issues, and that's why, again, in what's studied clinically, they're good treatments for like post-operative care. For a short period of time.
To have
right?
my knee rebuilt, and I think I took one of those suckers and I lost about 2 days of my life, and I was like, I'm done with.
Yeah, people get nausea.
I'll take some Advil. I'm good. Yeah. Don't give me any more of that.
Yeah, and again, if you had a big surgery, it's perfectly indicated. Or you had a big fracture, fine, right? You take it
'Cause it
for
hurts.
take it for a
It's
week or two.
painful.
We want you to keep moving and stay functional. It's just that for the long-term prescription, there's just the evidence for it's not very good. It just doesn't work that well, and that's a hard conversation to have with patients, right? Because a lot of patients feel like, well, you're a pain physician. I came to you for help. I have no other options. And they sort of feel like I'm withholding treatment from them by not giving them medication. When in reality, I'm just trying to do what's best, and that's what the evidence supports is that just prescribing medication for a long period of time has not shown to be very helpful in almost any patient. I say cancer patients sort of get a different view on treatment because they not only is their cancer can be painful, but also side effects from the treatments and surgeries and things. So, but yeah, these are delicate conversations to have with patients, and it's difficult, but that's you just try to do what's best. And
So, what do those pills do to people that they're so addictive? Like what?
yes, yeah.
What is it? Because I'm going to tell you, I took it. I just told you that. I lost 2 days of my life. Can't remember a thing that happened. And I don't want that. Like, so
yeah, people get like a euphoric feeling. So we sort of
I didn't experience that.
some people with side effects, the nausea and that kind of stuff is so severe, or the sedative properties where they're just like asleep. Which, just to touch on that really quick, that's what a lot of times we get for the cancer patients is patients with big invasive cancers a lot of times have to choose at some point, if it gets severe enough, choose between being basically asleep because of their pain medication or in horrible pain, right? Because it's just like they either take the meds and they're knocked out,
Sure.
they can't spend time with their loved ones, or they're in terrible pain. So those are a lot of patients that we get. But back to the other...
Which there's no win for that.
Right. So yeah, that's why patients, again, like those are the ones that usually, I mentioned like the pain pumps earlier. That's similar to the stimulator, but it's basically, it delivers medication through a catheter or a small tube directly into the spinal fluid. And they have an implanted pump about the size of a hockey puck that's under the skin. And basically every 3 to 6 months, they have it refilled. We can reprogram it. They have a basal infusion going all the time. And then they have a little device where they can give themselves boluses if they have breakthrough pain.
Okay.
So that's another option for those patients. But yeah, for the addictive portion, we try to stratify. There's dependence and there's addiction, right? So dependence is like a physiologic. Your body is just so used to having it that it's sort of like it is demanding that you take it in a sense. But addiction is dependence with all the social things, right? So like, they'll do anything to get the medication, and it destroys social aspects. And they have terrible cravings, and like all of these things sort of play into it. But yeah, it's just there's euphoria associated with a lot of the opioids, and that's how people get hooked. And then they're so dependent on them that again, like you get to this, and you hear this all the time. You get to a stage where you have to take them to feel normal, instead of taking the medications to get the high. So you're just trying to avoid the withdrawal at some point instead of taking medications.
So you don't just feel bad, which I've
Correct.
talked
And
with people.
This is for illicit drug use, right? Not like something we would prescribe, but but it can start with prescription meds. So you want to
Sure,
preface that.
absolutely.
Yeah.
I've talked with, folks that have done, illegal,
Yeah.
horrible stuff. And they're just like, I did heroin for, way longer than I should have because I just didn't want to feel bad.
Yeah.
I didn't feel good anymore.
And the more you
feel
sort of
bad.
take this where you get this high in the beginning, but then your baseline keeps dropping lower. So then you're almost taking it to get back to baseline at some point.
Which
So
is
that's
why
really
people
hard.
OD.
Yeah. Yeah. And the highest risk of overdose is in a relapse, right? So like after someone's they've gotten through the withdrawal, either by medication or they've just cold turkey stopped, suffered through that, they get clean for a while, they relapse and take a similar dose what they were doing before. And again, now maybe they have new receptors that are back again, like we talked about earlier, and that's by far the highest risk of overdose is in a relapse situation.
Wow. Which really doesn't have anything to do. Heroin doesn't have anything to do with your
But
profession,
right.
but it all kind of ties together on why the things work, why the pills do, why people get addicted to them, and
that's why I always try to have the conversation. Again, if someone feels like I'm withholding treatment because I'm not giving chronic opioids, I try to explain to them like this is just what the literature, the data, the studies support. Right? This is what's best. I'm trying to do what's best for you. And sometimes people get offended, like, well, I'm not a drug addict, I'm like, well, I'm not saying that. And even if you were, I have no judgment for that, right? I'm just saying that has nothing to do with getting hooked or addiction or all that. There's a lot of other medical side effects, and it will make you feel better for days to weeks.
Sure.
After that point, this is not going to serve you well, and that's why it's good after surgery, right? Because there's a clear endpoint. Your body heals.
Yeah, like you're going to get better. You're just trying to not
if
feel
you have a
bad
patient
while it's
that's-
healing.
Correct. So if you have a patient that's 50 years old that's inquiring about it and they have other options, that's always the conversation. It's like, where is this headed? You know, like it's sure a month from now you may be doing fine, but like, what about a decade or 2 decades? Like where we can't just keep this escalation of meds and all this
Right.
thing going. So that's why it's best not to start in almost every situation. So
Okay. And that's on you as a doctor to have to. That's kind of stressful that
It's
you
hard,
have to look at each patient and figure out what the best route of taking care of them is. And sometimes people don't like to hear what you have to say, I'm sure.
yeah.
Most of the time, I would say that they were like, "We love you. Thank you so much. You're helping me, and that's great."
Yeah, it's gratifying most of the time,
Yeah.
but it's very challenging, and it's just a very delicate conversations a lot of times. So you're trying to navigate, all of the permutations of all the things we just talked about. So
Yeah.
it's very rewarding, but it's like I said, if you can get a diagnosis and it's one area of the body for the most part that's bothering somebody, those are the ones we can help the most.
Yep.
So
Well, that makes sense. So, okay, how does somebody come to see you? Do they need a referral from their doctor, or, another doctor? Can they just call? How does that work?
yeah, so like I said, I'm always in Jackson, at least at this point. So we're here, we're taking patients, as soon as they get referred, we're trying to get them in right away since we're just sort of building practice at this point. But yeah, they can either get a referral from their primary care doc, they can call 1-855, the number 4 Holzer. It's 1-855-4-Holzer.
4 Holzer.
Or go to holzer.org/appointment, and they can get in that way. So
Yeah, here's the cool thing about Holzer. There's about 7 million different ways you can get an appointment. So it's really cool. And the website, if you haven't been on it, please check it out because you can make appointments right there online. It's really convenient.
yeah, and you can all the docs have pages on there. You can see kind of get an idea of what they do and where the educational background, all that kind of stuff. So
You're probably going to find a lot of doctors that are there that you're like, oh, wow, I didn't even know that was a thing. Or I
Yeah.
didn't know we had a doctor like that around here.
yeah,
So super duper cool.
yeah.
So what's your favorite thing about being back here in Southern Ohio?
Yeah. Well, I mean, I came from Louisville, as they say, right? It's not Louisville, so that had its own southern
Wait, did you get
charm.
to go to the Derby?
So we never went. But Derby time is always fun because it's a huge celebration. That's like their event, right? So
Yeah.
Louisville's known for bourbon and horse racing. That's like
Yes.
their two things. So the Derby always starts out like 2 weeks before. They have Thunder over Louisville, which is a huge fireworks display at night. They have an air show all day, and we live like 4 miles from downtown. So they have like F-22s and F-16s and the big bombers and stuff. So we'd see them like circling. It was kind of freaky to see them circling the house.
Yeah.
But that's always at Thunder time. So that's always a fun event, and my kids loved it and stuff. And then it just the spirit in the city is awesome leading up to Derby, all for a couple minutes of a horse
Yeah.
race. But we didn't go to the Derby, but yeah, it's a cool city though. A lot of interesting culture. But yeah, to be back, we were in this area when from birth to 1 year old for my oldest, and then we've been gone ever since. So obviously not, and it's not terribly far. It's 3.5 hour drive, but not having family support. We're happy to be back and have family. And this is how I grew up, family, friends in the area,
Sure.
cousins, big, traditional Appalachian family network, right?
Hey, cousins are the best brothers and sisters too,
and
right?
we-
Cousins are great.
Yeah, exactly. So, and we wanted our kids to have that. So, to have that experience growing up too. So, yeah, it's been great being back. We, my wife and I, she's from Vinton County. She moved to Oak Hill so she graduated from Oak Hill as well. So, it was important to us. We wanted to, when we were looking at jobs, we looked at, big academic institutions and private practices, and we finally just decided this is a community that raised us, right? So we want to come back and sort of re-immerse ourselves in the community and give back and serve this community and raise our kids here. So that was important to us.
Awesome.
And we're very, very happy to be back and settled in and getting things started with school and all that fun stuff. So, yeah.
Well, we're happy to have you here. Support this guy if you have any pain. If things are if you're kind of at your wit's end, call Holzer.
Yeah, well, definitely. I mean, like I said, we can't fix everything, but we'll do our best to find a solution for you to try to help you out. So
Yeah. Well, Dr. Dylan Lewis, we thank you so much for being here today. It has been so fun talking with you.
yeah, I appreciate the time and thanks for having me.
Yeah, and if anybody has any questions, just give them a call at Holzer, and they can answer that for you.
Yep,
We can get you scheduled in.
we'll do that.
Yeah. All right. Well, let's hear from our friends at Vinton County Bank. And then Pete Wilson is in the house. We're going to do some news. So we'll be right back.
At Vinton County National Bank, we believe in supporting the areas where we live and work. Now, we'd like to honor those who also serve our communities. Our new Community Champions account is especially for first responders, veterans, active military, and anyone employed in the fields of healthcare or education. This account offers rewards, discounts, and other benefits to those who give so much to others. Vinton County National Bank, rewarding those who serve.
Some of the remnants of Hurricane Debbie are headed our way. They say the most chance, I think, the end of the week for us to get some of the shall we say, remnants of the rain and storms and all that stuff. But, we don't know that forecast right there doesn't really reflect that, but that's kind of what I had heard this morning. So we're going to go with that. But very, very hot the next few days. So please, please, please be very careful outside. I was letting the dogs out this morning early and I was sweating outside, walking around the yard. So just be very careful. It's going to be near 100 degrees today, and there is a little chance of rain there in the forecast. So looks like maybe as we get toward the weekend, it should cool off. So, but just be careful the next couple of days.
Okay, what feels better than a hot shower, right?
Ugh.
Okay, maybe not that kind of hot shower. All right. Well, that's what we would have today if it does rain.
Dude, I'm telling you. And can you imagine 100 degrees and 100% humidity? I mean, just ugh.
Okay.
Ick.
Stay inside, right?
And the flowers are all like,
no,
I'm choking.
They don't have the chance to escape.
No,
do
they don't. Poor things.
All right. Well, we do have some news to throw at you.
Okay.
Kind of a big story out of the Jackson County Department of Job and Family Services.
Okay.
SNAP benefits. SNAP is the acronym for the Supplemental Nutrition Assistance Program. In past years, yesteryear, we used to call that the food stamp program. This is the successor program now. Well, anyway, up to 100 recipients here in Jackson County have reported to the Job and Family Services Office, and there could be more, obviously, but these are the reports that have come in. Just Monday, 100 persons have had their benefits stolen electronically.
What?
Yeah, absolutely. Tammy Osborne Smith, who is the director.
Oh my gosh.
I know, exactly. It's kind of like, I'm certainly not an expert on, the plastic cards and all like that, but it's supposed to be a card skimming type con where,
Oh no.
100 people have had, money stolen by what they presume is card skimming. Because, you use your cards, when you get your benefits. And 100 people.
Is that just in this area?
In Jackson County. I don't know whether, this is a problem in other places or this is isolated to Jackson County, but that's what we know
moly.
about right now.
Okay.
The good news is that, due to a federal program and legislation, those benefits will be reinstated. It's not like, you lost your wallet and you're out of the money. They will be reinstated, but you have to go through a process for that, and people count on being able to get this assistance to make sure that they can get, all the food and the type of food they need to be healthy and nutritious. And Tammy Osborne Smith says that staff is working, with the public, trying to identify all the people who lost benefits and then to get the benefits reinstated for those persons who lost it. In December 2022, Congress passed a law to protect and replace SNAP benefits that have been stolen via card skimming. So obviously this is something that has happened quite a bit in the past all over the country. And so this is going on now. I've not heard that I'm sure that there's been cases of this before, but this is the most that I've heard of.
That's a lot.
In the news. Tammy Osborne Smith contacted us to help get the word out on that. And so if you haven't realized yet that maybe your benefits have been lost, check that out. So if you have lost the benefits, you can start the process to get them returned to you. But there's different ways that you can kind of protect your card. You never want to give out your number. Of course, you never want anybody to see when you're putting the card in to use it and to activate it. You can change your PIN number. Don't share your PIN number. It's kind of like along the lines of sharing credit card and debit card information.
Right.
So we will be monitoring that. We have a abbreviated story online, and we'll have a more detailed story, including with some tips on how to protect, the integrity of your card for these SNAP benefits. That's the Supplemental Nutrition Assistance Program. That is a federal program that comes through the states and then down into the counties for distribution and administration. All right. Today you can do something in Ohio that you couldn't do yesterday.
I know. I saw that this morning.
Right, and that is purchase non-medical marijuana, more popularly known as recreational marijuana. You recall back in 2016, a legislation was passed that set it up for medical marijuana, but that has to be prescribed by a doctor, and there's been dispensaries across the state who have done the medical marijuana. Many of those dispensaries will now be able, but it's a separate regulatory thing, can do the recreational marijuana or the non-medical marijuana. 98 licenses have been issued by a new. It's out of the Ohio Department of Commerce. It's called the Division of Cannabis Control.
Yes.
All right. Cannabis and marijuana kind of interchangeable, but marijuana is kind of like the juiced up derivative of the cannabis plant, that we know about. But anyway, one of those 98 dispensaries that is regulated and can start to sell the recreational marijuana is the Herbal Wellness Center at 3 AC Avenue in Jackson.
So they are included in that?
They are included in that. It used to be Buckeye Botanicals.
Yes.
Not all that long ago. I'm not sure when that changed or what the ownership is, but it's now the Herbal Wellness Center at 3 AC Avenue out there right off McCarty Lane. I talked.
But there's a line out the door this morning.
Right there is there is the building. In case it's out there, just across from the Parmar convenience store.
Yeah.
Down the road from the Red Roof Inn.
Yeah, right by 84
like
Lumber.
Exactly.
The Red Roof Inn, yeah.
Right there, just by the roundabout if you're driving out that way. But that is the Herbal Wellness Center. I talked to the general manager, Justin Miller. And not all the dispensaries that are licensed are ready to sell necessarily. You have to jump through some hoops. This one is, though.
Okay.
So at the Herbal Wellness Center, they could be doing, and probably are doing, recreational marijuana sales. And it's pretty simple. All you have to do is be at least 21 years old.
Sorry, Dylan.
To use or possess marijuana, including up to 2.5 ounces of marijuana. And the law also, a lot of people don't realize this, it also allows adults to grow up to 6 plants per individual and up to 12 plants per household at home. Now, the state does have its hand in the till. 10% of the revenue will go to the state. So, they always,
well, of course they do.
Well, that's always kind of like behind the scenes.
It's how we get things passed.
A benefit. Oh, yeah, they see some income coming in, whether it's they tax your gasoline, they tax your liquor, or whatever. But they also will do this with marijuana. 10% state tax on marijuana sales. So if there's a 10% markup, it's because state government has to get its cut. But I talked, as I said, to Justin Miller. He told me that all you have to do if you want recreational marijuana is to, of course, you have to have the valid ID to show that you're 21. And he said that purchases will be limited up to 1 ounce a day. Now, I don't have a price list or anything, but I guess relatively speaking, it's kind of pricey because of the supply and the demand and like that.
Okay.
But, different forms of marijuana, the vapes, the flowers should all be available there.
Sure.
And you can go on their website and check out the hours and so forth. But today, they are selling the recreational marijuana. That location, before it was Buckeye Botanicals, they had the medical marijuana before. So some people maybe who had the prescription for the medical marijuana know where that location is and is familiar with it. As far as other dispensaries nearby, Athens, Waverly, Jeffersonville, Marietta, Logan, Hillsborough, and Chillicothe. Not all of them necessarily are ready to sell, but they have the licenses to. They're just in the process of being ready. And I don't have a breakdown on who has it and who doesn't, other than the Jackson location is a go. So recreational marijuana now available in Ohio. Of course, that's a result of a constitutional state amendment, issue 2, that was passed in the November 2023.
Voted in by the.
And it wasn't close, 57% to 42%.
I couldn't believe it, to be honest with you, but
right. Jackson County.
look at us go.
Jackson County was one of the few counties that voted no on it. It was close.
A little conservative down here, maybe.
Benton County said thumbs up by just a narrow margin. So in the cities and like that, it was overwhelming in support. In the rural areas, not so much. It was kind of, you had people thinking both ways. Now, I talked to, this is an important thing to throw in there. I talked to Jackson Police Chief Brent Hinch about it. He said that he is not worried that much about the law enforcement end of it because, of course, possession of marijuana as a crime has kind of disappeared anyway.
It's the least of their worries. Let's just put it that way.
Exactly. What people may not realize, though, are the restrictions to use marijuana. Now you can buy it, but there are restrictions. You cannot use it in public places.
Right.
All right. For instance, they can't come into your restaurant and smoke. I know that's a private business, but it's also considered a public place.
Right.
Can't be out in the parking lot, out on the sidewalk, in an arena, and use marijuana. You can have it, but you cannot use it.
Right. So basically,
So it's on private property, like one's residence or somebody else's residence or whatever. And I'm not sure. The private clubs and so forth, I don't know whether that is considered a public place. Probably it is. I don't know.
Well, see.
And you can't drive and use marijuana at the same time for the same reason you can't drink and drive.
So here's the thing. It's all clear as mud. I know, for example, that we've gotten some letters from the Division of Liquor Control about it. And, if you have a liquor license, then obviously you don't want to make them angry. So there's some regulations with that. But it's all going to be something that we need to learn over time.
Exactly. And
it'd be great if we could get some people in here to kind of talk about that.
I'm sure Chief Hinch would be willing to do that. And, there's probably other people in law enforcement or who deal with this issue who would be able to do that.
Hey, Dylan, let's schedule Weed Week. We can have weed topics every day.
But while you can now that you can possess marijuana and buy marijuana, to use marijuana in a public place, that is a minor misdemeanor. So you can still break the law with marijuana.
Yeah.
So make that distinction very clear.
Yeah.
No
Just
public places.
Do it at home or your buddy's house or something.
Right. Okay. Some other things to tell you real quick here as we're running out of time. The Jackson Apple Tower, it's been undercover a little bit. It should be undercover again because they should begin painting this week.
That was what it looked like. Look at that. It is crazy.
That's a crazy looking thing. Well, it looks like almost like the Devil's Tower or something
in the middle of Jackson. I drove by yesterday and it looked like that. And I was like, whoa, how'd they get that much material?
But the reason, they had the needles out of there too, but that is to kind of hold the cover up there.
Yeah.
And when they paint, that cover will be on and that will prevent other things from being painted other than the tower.
Exactly.
Down below or whatever. Especially the wind blowing, you can imagine what might happen there.
Every car in Jackson would be red.
A different kind of shower, right?
Yes.
But they expect, according to Jeremiah Shaver, who talked with some of the contractors there on site, they do expect to start on that early this week. They may be doing it now, who knows?
Okay.
And they do want to have it done by the end of August, so it will be ready for the Apple Festival for sure.
Cool.
All right, one other thing we want to tell you real quick. The Jackson County Health Department, and this is a great public service thing that they're doing, they are now providing free clinical services at the Grace Clinic in Wellston. The Grace Clinic was the private sector, nonprofit, goodwill thing where it's open once a week, and medical professionals and other volunteers provide their services free of charge to people who are uninsured or have low insurance. It's in downtown Wellston at 22 South Ohio Avenue. Now and that's on Tuesdays that they do that, on Tuesday evenings. Now on Wednesday evenings from 8 a.m. to 4, they're going to be at Grace Clinic. I'm talking about the health department, and they will be offering adult and child wellness visits, postpartum visits, PAP breast exams, preconception wellness, blood work, school and sports physicals, vaccines, STI testing, and more.
Okay.
So all these screenings,
That's awesome.
all these screenings free of charge, available at the Grace Clinic, thanks to the good offices of the Jackson County Health Department. So we have that online. It will be in the paper, and we'll keep reminding you because it's something new, and it really fills the gap for those folks who otherwise could not afford to have these examinations and screenings. All right, so also we want to tell you, Jennifer, that project, the water line replacement project, is continuing on South Street in Jackson. It is in the final stages. I think I knew they
Thank
wanted to have
goodness.
it done this month. I think the line is laid or mostly laid, but they're doing connections. And of course, you know, they're still paving over the streets where they had to tear it up a little bit for the laterals. There was some water service disruptions on South Street because, you know, they were tying in, you know, the new line with individual connections for customers. And there may have been, and they maybe still will be, hadn't heard anything new about this today, there may be short-term water service disruptions while this is taking place.
Okay. Be patient. It's all for progress.
But we're almost done.
Yes.
All right, so that's what I have. We'll have more tomorrow. How's that?
Well, that sounds great. So have you had water line disruptions?
Very briefly.
Okay.
Very briefly, it was early in the process. I live on West South Street, and they started on that end. And as you can see, if you're driving on South Street or crossing through or whatever, it's on the east side of South Street near the Main Street intersection,
Yep.
where a lot of that work is taking
Almost
place.
made it.
But remember, that was a 100-year-old line that they're replacing, and you're just asking for trouble.
Yes, you are.
You know, it's so easy for the city administrations to pass that along to the next generation because, you know, it's cost so much. But grant money has been available. The city of Jackson has more match money available now because of the income tax. I'm not trying to promote the income tax, but that's a fact.
Yep.
So there's much more projects being done. There's more grants coming in. The money is flowing from Washington and Columbus, so we need to take advantage of it.
There you go. All right. Well, thank you so much to everyone for tuning in today. Hope you learned a lot from Dr. Dylan Lewis about pain management and the things that they can do to help you out along the way there at Holzer, and welcome him to the community. And Pete, thank you for letting us know what's the latest and greatest in news.
All right. Well, very good. There's always new news
There's
to
always
report.
something. New news.
We'll be back tomorrow
That's
with the
right.
latest.
So have a great day, everyone. Thank you so much, and we'll see you tomorrow. Bye-bye.